All right, it looks like the waiting room is slowing down, so we'll go ahead and get started. Thanks everybody for joining us. I'm so glad we were able to have Pat Deegan this morning. It was just a really wonderful use of our time, and I hope all of you were able to glean something from what she had to say. I want to welcome you to the part two of our New Journeys overview. Many of you likely attended part one of this talk last week. And this week, we'll really be taking a deeper dive into Washington's model of coordinated specialty care. And you'll have an opportunity to hear from providers about additional team member roles, as well as the referral process. So looking at today, we'll just do some quick introductions and we'll dive in. My name is Cami Peretta, and I am the New Journeys Program Director Trainer with the Spirit Lab at the University of Washington. I have actually been involved with the New Journeys network since 2016 and have experience on the ground level implementing New Journeys, as well as working at the Healthcare Authority to support the expansion of the model throughout the state. Today, I'm joined by Catherine LeBranch and Gardenia Roman Duran. Catherine, Gardenia, do you want to say hi and say a little bit about yourselves before we hop in?
Yeah, hello, I'm Catherine. I am a current program director in family education specialist at Behavioral Health Resources in Olympia, and I've been with New Journeys program for just about 5.5 years now.
Good morning, everybody. I'm Gardenia, and I'm the Individual Resiliency Trainer, or IRT, as we like our acronyms here. And I've been with New Journeys in various roles for about almost 4 years now, so coming close.
I'm excited to be presenting with Catherine and Gardenia today because we used to be on a team together. And so it's always fun when we get to come back together and continue collaborating. So these are our presentation overview objectives, two different words. We're going to just review some of the facts that Maria shared during part one of this presentation, just to kind of get us oriented into today's talk. We'll talk a little bit about New Journeys measurement-based care outcomes in Washington State, the expansion of our New Journeys sites to date. We'll talk about the no wrong door referral process and highlight a few team member roles, and we'll leave some time at the end for question and answer. So looking at the problem facing us today, each year about 100,000 young people experience a first episode of psychosis. What that equates to is that 274 young people each day. Many of these individuals and families will go without care for long periods of time. In the United States, the average duration of untreated psychosis is more than 2 years, in spite of the fact that the World Health Organization suggests that specialty care for first episode should start within the first 3 months of the onset of the illness. Here's why that's a really big problem. Longer duration of untreated psychosis is related to more frequent relapse, a longer course of illness, and more profound disability. So thinking again about that problem facing us today, schizophrenia is rated as the 11th leading cause of global disability. So while it's a relatively low prevalence disorder, the burden of disease for psychosis and schizophrenia spectrum disorder in particular is substantial. Psychosis is associated with high disability, accounting for a significant proportion of Social Security expenditures with enormous personal and societal costs. People who experience psychotic disorders are also at higher risk of poor long-term health outcomes and decreased life expectancy. Suicide rates are higher with this population, as are rates of homelessness and incarceration in this population. So like we talked about last week, part of the solution for this problem is coordinated specialty care, which in Washington is called New Journeys. So I'm going to share a little bit about our measurement-based care. These are not my slides. I borrowed them from Washington State University. And so I'm going to do my best to do them justice and share the information accurately. I will also have at the end of this portion of the presentation, I'll share some contact information. So if you do have questions about any of this information, it will be available to you. So thinking about New Journeys, we are an evidence-based practice. We also use measurement-informed care. What this means is we have various standardized measurement tools, which not only inform our treatment, but also inform future model development. This information that we collect has really demonstrated the effectiveness of our New Journeys model over the last few years. The PRISM collaboration at Washington State University leads our network's measurement-based care process, and they provide an annual evaluation by using the data that's collected from our New Journeys teams. The WSU annual evaluation provides both qualitative and quantitative data analysis to inform program development and collects program-specific information pertaining to outreach, outcomes, and individual experiences. Overall, what this data has shown us is that New Journeys is necessary for our Washington communities. We see this through the number of referrals and screenings that are completed annually. We see that individuals are motivated to receive services, which we'll see in the percentage of engagement, especially by the individual's natural supports. We also see that while New Journeys is designed to specifically address psychosis, people who are served by this model really experience a lot of other additional benefits in symptom reduction related to depression and anxiety, and they also experience an increased sense of well-being and recovery. I'll share a few of those specific findings with you. So looking at the numbers since 2015, New Journeys has received 1,387 unique referrals across the state. Of these individuals, 709 received services from New Journeys teams. When we look at our service utilization, I think one of the most exciting findings is that the rate of which people were engaging in New Journeys services during the pandemic didn't dip. This isn't what we saw across many other programs being provided across the state. So that's really exciting. We saw that overall 89% of scheduled appointments are continuing to be attended, which tells us that people who are being scheduled for services really want to be involved in them. Since 2015, our providers have scheduled 31,048 sessions, of which 24,620 have been attended. This is representative of 562 individuals that we had data for. And in 2021, one of the really cool statistics was that 4,404 family education sessions were scheduled and 4,304 family education sessions were attended. So you can see that the model is working. People want to show up to their appointments because they're finding the services are helpful. Looking at the demographics, we can see that New Journeys serves a pretty diverse clientele, especially considering Washington State's demographics. This means that we really need to work within our network and within our teams to develop culturally responsive and inclusive services throughout our various sites. I'll talk a little bit about some of those efforts here in a moment. So looking at this slide here, what we see is baseline characteristics of an individual at intake. Anything that's here in this darker blue color indicates a clinically significant level of a symptom when an individual started with a New Journeys team. What we see is that 54% of individuals rated moderate to severe depression at intake. They also rated 47% rated moderate to severe levels of anxiety. 36% of individuals indicated some level of suicidal thinking, and 71% indicated some kind of substance use. Now, these are all things that they're reporting over and above the psychosis that they were experiencing. So I want to keep these numbers in mind as we move through our next slides. This slide shows the clinical measures of psychosis. So we can see both a scale that was rated by the individual, as well as a scale that was rated by clinicians over time. So once someone is enrolled in New Journeys, symptoms are tracked for up to 2 years. However, I want to note that this doesn't mean that we have information for every individual enrolled for the entire 2 years. Not everyone continues to engage in New Journeys. People may have moved on for various reasons. And the other caveat is that we're really still learning how to deploy measurement-based care in an effective way within all of our programs. So what you see here is that we do see a decline in psychosis symptoms over time. Now, the client-rated symptoms of psychosis may not appear to be very clinically significant, but it does follow the same pattern that we see in the clinician rated symptoms of psychosis, which would tell us that symptoms are still decreasing over time. Yep, I lost my thought for a minute, so I'll just keep moving. Anyways, with symptoms of anxiety and depression, we also see positive impacts on those symptoms, like I referenced earlier. Here you can see a clear decline in the experiences of anxiety and depression for those who engage with our teams. I think this really speaks to the level of support that New Journeys can provide, as well as the level of rapport that teams are able to develop with individuals to help them really, like Pat was saying, to find what's important to them and continue moving forward. When we look at the substance use, we don't see as much of an impact to substance use in our New Journeys teams. We see some impact, but what this really shows is that we really need to be able to adequately address substance use in individuals experiencing first episode who are engaging in a New Journeys team. It can sometimes be difficult to determine what came first. Did substance use trigger psychosis, or did the psychosis result in substance use? Our teams are often able to engage with individuals to begin teasing out some of this over time. Currently, both WSU and UW are working to create solutions to really support this part of the model and support individuals. So I think Pat mentioned in her talk that, it's not all about clinical outcomes, right? We really want to think about what is important to an individual and how are we affecting change in those areas. So our data collection does also address functional outcomes. What we see here is that our teams are really doing a great job of helping people to get back into school or enroll in secondary education. People are able to engage with our New Journeys teams to increase their vocational services, which speaks to the C component, which we talked a little bit about last week in part 1. And people are really finding ways to create meaningful and sustainable health outcomes with the support of New Journeys teams. So if you have any questions or concerns about this evaluation data, here's the information for our evaluation team, and they would be able to answer questions for you about that. Other metrics that are being accounted for are incidence and population data, which has been generated by the Research and Data Analysis Division of DSHS. In 2021, it was estimated that more than 2,000 youth and young adults in Washington experienced a first episode of psychosis. This equates to 235 individuals per 100,000 Medicaid enrollees who will experience a first episode of psychosis in Washington. This is a low estimate, as it only accounts for individuals who are receiving Medicaid and those duly enrolled in Medicare. These rates are comparable with incidence rates that we see nationwide. This information is currently being used to spearhead expansion and access to New Journeys across the state. So this is a map of our current sites. We currently have 17 sites in 9 regions of Washington, which this map demonstrates. I want to make sure that I reference the interactive map that's on the New Journeys virtual gathering platform. On that, you can hover over each one of the sites and it will show you contact information, websites, referral information, as well as any job openings that that site may have. As we continue to expand throughout our state, our focus really is on increasing equitable access. On this map, you can see the little blue triangles here indicate that we have pilot sites. So one of these sites, Lummi Nation up here, will focus on a tribal adaptation of the model, which will really aim to address the unique needs of those living in an American Indian community. This work is being led by our partners at WSU. So far, they have worked with the Lummi tribe to conduct meetings with a community advisory board, which will really help to guide their next steps. And they have also started on a language review of the New Journeys manuals and other materials, which will allow for a more culturally responsive New Journeys level of care to be provided at this location. We'll also be able to take lessons learned from this work and apply it across all of our sites. And then here we have 2 rural pilot sites that will be starting, and this will really aim to create more of a hub and spoke model, which will ultimately increase the access excuse me, of these vital services in our rural regions of the state. These efforts will address diversity, equity, and inclusion within our evidence-based work. So now I've given you a lot of history. I've given you a lot of the numbers and things like that. So now we'll talk about some of the more nitty-gritty kind of functional pieces of the model that you may be more interested in learning about today. So this is the New Journeys admission criteria. We really want to think about New Journeys as a treatment match model. What I mean by that is that not everybody who is experiencing psychosis would be a good fit for New Journeys. We don't want somebody who is experiencing psychosis due to a medical condition or due to perhaps some psychotic-like experiences due to trauma or due to depression. We don't want to put them into a model where they're being taught about things like schizophrenia and they're being taught about managing some of these symptoms for a longer course of time. So we really want to think about, is this person a good match as far as their age, the duration of their symptoms, as well as the diagnosis that they're experiencing. Our program directors are really trained to help figure out what the diagnosis is and tease out any underlying causes of the psychosis. We don't rely on our community members or other providers to do this, which leads us to talking more about the no wrong door referral model that is used by our teams. So on this slide, I really think about the no wrong door. No wrong door means that we want to allow you to make a referral or access a New Journeys team in a way that is really low barrier. So the referral process really can start with community education, exactly what we're doing here today. Many of our program directors and our teams are doing this kind of education and outreach within their own communities. If you live in a region where a New Journeys team is available, I want to encourage you to reach out to the team or myself to come talk to your agency or your team about these services. If you, so what we can do in that kind of a community outreach thing is we can teach your teams how to identify first episode psychosis, and we can teach you a little bit more about the referral process as it relates to that individual region. It's really important that we're able to do that kind of education and outreach regularly, because as organizations and communities experience turnover, new staff are still getting this vital information. You are all the eyes and ears of the community, as I mentioned earlier. And if we are to truly reduce the duration of untreated psychosis and ensure that young people are getting treatment that they need, we need to be interfacing with our communities regularly. So thinking about the next step in our referral process would really be consultation and pre-screening. By having those existing relationships within the community, it makes it easier for providers, school staff, and families to reach out to our teams and just ask questions. This kind of consultation can help to determine if a referral is needed, and it also provides a really valuable resource to our communities. This informal consultation can also act as a pre-screening to help determine if a more formal referral or formal assessment might be necessary. If a pre-screening or consultation suggests that an individual might need further evaluation, the next step would be to arrange an in-person or more in-depth evaluation with the individual. This could also include their natural supports if they so chose. This is when we would consider that a referral has been made. Many of our teams have referral forms that can be submitted online or via fax, email, things like that. But a lot of our teams also take information just over the phone. Our teams truly try to go the extra mile to complete outreach to the individual and the family once they've been referred, to really engage them in that assessment process and remove any barriers. This extra support doesn't stop during the screening process, but really persists throughout an individual's time and care, and serves to decrease the dropout rates that we might see in this underserved population. During the screening and referral process, if the diagnosis is unclear, again, the program director is trained in differential diagnosis. They are all trained in the structured clinical interview for the DSM-5, and so they can use that as a tool to help them figure out what's going on and facilitate the best possible care for that individual based on their assessment. When things are a little bit more unclear, many of our teams also have access to the University of Washington's Central Assessment for Psychosis services. And this would allow for more in-depth psychological or neuropsychological testing or evaluation to be completed if indicated. Our teams also have access to UW-sponsored differential diagnosis calls each month, where they can get some additional support on helping them figure out what's going on for an individual. This means that even if New Journeys doesn't end up being the best fit for someone, our teams are able to provide a really vital service to help families and individuals to figure out what's going on. So if it's determined that somebody is eligible for New Journeys based on the screening, they would have the option to complete an intake with that team and engage in the array of services, which we'll talk a little bit more about here in a second. In some cases, it does take months to figure out what's truly going on for an individual. And in these scenarios, many of our teams are able to do a provisional enrollment while informing the individual and their natural supports that as they gain clarity over time, the individual may need to transition to a more appropriate services if that's indicated. We would see this most often in differentiating if the symptoms were due to substance use versus a diagnosis of a schizophrenia spectrum disorder. It's important to note that our teams provide community-based services. This could include anything from the screening process on, and so it means that services can be provided within a clinic or community setting, wherever the individual is most comfortable. I want to pause for any additions that Catherine might have as a program director.
Yeah, I think just want to reemphasize what Cami mentioned, like there's no wrong door. I am always happy to take calls from anybody. I think that we do have like a formal referral form, but I don't want that to discourage people or maybe because they're not able to check as many boxes, they feel like maybe it's not going to be an appropriate fit. Like Cami said, we're all about community education and that consultation. So I'm always open to people calling and asking questions. Referrals don't need to come from a hospital or from a provider. So I think I get, in my experience, I've gotten lots of families calling and just being able to talk through what their loved one is experiencing and be able to answer any questions or direct them to, if it doesn't seem like my program would be a good fit, being able to direct them to other services that might be a better fit first, I think is really important. So I always am I think the culture of New Journeys programs and program directors that I know in the network is that we're all open to questions, want people to reach out. We want to get our name out there. We want to get information about psychosis out there and to be able to provide good services to individuals. So we're flexible. We want questions and no wrong door.
Thanks, Catherine. So now we'll look at some of the family or the family roles. We'll look at the New Journeys team member roles. Last week, we talked about family education and C services. I think more briefly, Maria had reviewed the roles of the nurse and the pharmacological interventions. Today, we're really going to look at the IRT role, which, as Gardenia mentioned, we love our acronyms, stands for Individual Resiliency Training, as well as peer support and case management. Before we hop into that, I just love to pause and look at this quote, which is from a New Journeys graduate. And it says, "My goal is to work with animals in the medical field. If I hadn't gotten diagnosed, medicated, or hadn't had the support of New Journeys, I would likely not be able to pursue my goal to be to the place I want to be. Their support is invaluable to me." And I really love to just pause and reflect on that quote, because I think about this image that we have of our New Journeys wheel here as really wrapping around an individual and providing them with the support that they need to be able to move forward with what it is that's most important to them. So with that, I'm going to kick it over to Gardenia, who's going to talk to us a little bit more about individual resiliency training therapy.
All right. Welcome back, everybody, to me. So with IRT, the way that that I engage with folks, really just processing their experience with psychosis, thinking about using our modular, our modular treatment program through the Navigate model, and just pulling from CBT perspectives, pulling from strengths-based perspectives, and really using that to make the care that we provide just as individual as possible to everybody that I work with. And I think that's a very common thing that you'll see with all of our IRT providers within New Journeys. With that said, overall, IRT is meant to instill hope in participants. That's something that we lean into. We want participants to know that they can lead full lives, that they can lead rewarding lives, in addition to having experienced psychosis. So the way that we do that is in teaching people social skills, teaching them what resiliency is, right? That ability to bounce back from tough stuff, and just leaning into the strengths that the individual has that have supported them and being able to be resilient throughout their lifetimes. We lean into the goals that participants have, and a really heavy emphasis on shared language. So that looks like defining wellness, defining what symptom experiences look like for each individual, and really just being mindful and respectful of teaching folks like what does it mean to experience psychosis, but also kind of leveling with individuals about how like maybe my top concern or my top symptom that I want to work on is like anxiety, for example. Really leaning into what it is that the individual wants to achieve, so that we're able to use that common ground to move forward. So that all has to do with that strengths perspective that I mentioned earlier. Overall, we really want to reduce self-stigmatizing beliefs that people have. I think that's a common thing that we see a lot within therapy in general. Stigma about what it means to come to therapy, to even have participated in like programs in the hospital, and so on and so forth, and beliefs that individuals have about themselves and what it means to experience psychosis, amongst other symptoms. And we're working collaboratively to just troubleshoot all of that with people. So with that said, I do have some examples about what it looks like to use all of these things. So when we finally get into the nitty-gritty about psychoeducation, right? What it actually looks like to use coping strategies, whether it's teaching people some breathing exercises, teaching folks how to use their strengths in a way that's most helpful to them, even identifying their strengths in the first place, the therapeutic alliance and establishing trust, being able to process the trauma that can come from psychosis and other experiences in life, and just all of the jargon, right? So heavy emphasis on stress vulnerability model, what it looks like to be stressed, what it looks like to have influence from other factors, whether it's biological vulnerabilities and so forth, and how those affect symptoms. But in a nutshell, I want to give you guys a couple of examples of what this looks like. So with one client that I've been working with for about a year now, initially he was very apprehensive to work with the team and had challenges engaging with us because of paranoia and just really not having a great flavor in his mouth about what it means to engage in treatment. Through rapport building, through being able to focus on the client's identified distress, which was anxiety for this particular person, we were able to pair with him to just work on therapy goals, to work on job development goals as well. And this individual now engages regularly in treatment with us and has been able to participate in things like exposure work, which was a really big piece of his recovery, and is now working. So just a little bit of context and what it can look like to go through a program and what it looks like in real life with the participants that we serve. Not everybody's recovery story looks like this. For some people, they come through our program through an LRA, or a least restrictive agreement. And I have one individual that I'm thinking of in particular who her LRA has long expired now. She's still working with us, has goals to attend beauty school, has goals to just continue fostering wellness, which to her looks like preventing hospitalization. And recently she opted to stop medication and had a horrible experience with that. But through the therapeutic alliance that we've established, she was able to be honest about how this was something that happened for her. And we've been able to take that and really focus on on what matters to her versus what's the matter with me, which I think is a concept that we use a lot from Pat Deegan. So I hope that those examples are helpful as you think about how the IRT role works in individuals' lives, and just really what that work looks like when we're in the weeds working with individuals.
Thanks, Gardenia. The other part that we want to talk about today is peer support. It can be really an invaluable service for a lot of individuals and help the treatment team overall. Certified peer counselors are able to come alongside individuals using their own lived experience of mental health recovery. This becomes really important to instill hope that individuals can move past their current situation and that recovery is possible. Peers help to reinforce and practice skills that are being used in sessions and really serve as strong advocates even within their own treatment teams. Catherine, I know that you have the opportunity to work closely with a peer on your team and also supervise a peer. Can you share some of your experiences of working with a peer on the New Journeys team?
Yeah, as Cami said, I am not a peer specialist, but I have had the opportunity to work with a peer on the team when I was an IRT. And so I got to work very closely. And I think that peer support specialists are so valuable to our New Journeys teams because they not only are to our individuals, but to our staff on the team to be able to be we have a lot of clinical minds on a team, and then to be able to bring a human perspective to things, to be able to check us in the language that we're using, in the ways that we're conceptualizing, supporting an individual. I think the peer serves an important role in being able to ground us, and we're working with a human, and we are all humans, but we got to keep that in perspective. And like Gardenia had said, I think one thing that always comes back to me when I think about peer work is Pat Deegan's, what she said about, it's not what is the matter with me, but what matters to me. And I think a peer really brings that to life, and being able to partner with a peer, and the clinician teaches coping skills, but what does that really look like in real life situations? A peer is able to go out in the community and really meet that person where they're at and show them how this is applicable and how this is practical in life, and maybe also tell them how it doesn't make sense, and things like that. So I think it, like I said, it really brings that human aspect to it. I can think of one example of when I am so grateful to have a peer on the team is when I had an individual who was suicidal. He had called me on the phone. I was his therapist at that time. He called me on the phone and he was actively attempting to hurt himself by driving into oncoming traffic. And I was able to get on a 3-way call with the peer, myself, and that individual. And we were able to talk him off the road, and then help him kind of navigate through his feelings and his thoughts and where he was at, and then be able to get him to home safely. And to share with a family member about okay, this is what's going on for me and how can you help keep me safe? This was in, I think, kind of prime time of COVID. So it was also very hard to figure out how that looks doing it remotely. because we are like, when our individuals have crisis like that, it's nice to be able to be hands-on and to have someone who felt comfortable enough to call and talk to the team, I think wouldn't have happened the way it did if I did not have a peer. And so I think they are so valuable in what they offer to the group and what they offer to our teams.
That was a really great example. Thanks, Catherine. The last but not least kind of role that we want to make sure that we're highlighting is case management. And I think case management comes in a lot of different forms. I think many of our teams, all of the team members kind of wrap around an individual to provide case management. A lot of our teams also have individual case managers who are able to provide that kind of individual support that somebody may need. We know that people often come into services and they have a lot of different needs. And the primary goal for our New Journeys teams is to help them to stabilize during those initial months. And sometimes that means meeting their most basic needs. It could be things like transportation, getting enrolled with insurance benefits, taking care of their medical needs. And so, Catherine, did you want to share anything about your experiences as a case manager?
Yeah, another thing that I did, my first experience with New Journeys, I came on as a case manager, and I really like to think of this role as kind of like, I always explain it to people as like, it's the nitty gritty of all of the things, because you really get to be hands-on, you get to be task oriented. And it's also really, I think, enjoyable work because you get to see the outcomes right away. You get to kind of partner with somebody and go with them to DSHS and sit in the lobby for 5 hours and see the outcome of getting benefits. Or you get to go partner with somebody and take them to like connect with a parenting group and help them kind of socialize and reintegrate those things into their lives. So I think case management is really just like helping break down those barriers, troubleshooting where there's things that are maybe out in the community, and like I said, more hands-on that you don't get in office.
Absolutely. Well, that is the end of our presentation today. We want to say thank you to everybody for joining us and for listening in. We hope that this information was helpful. And we want to use the last few minutes that we have for questions. So I'm going to stop share and check the chat here. So the first question I see is 100,000 in Washington, in the US, in the world. So if we're talking about each year 100,000 young adults experience a first episode of psychosis, that would be in the US. Could that be due to not employee SUDPT? I'm not sure what part of I'm not sure what part of the presentation that was referencing. So if anybody wants to hop on and give me a little bit of context for that question, I'd be happy to try to answer it.
Hi there. So it was the part where you were referencing that you're not really seeing a lot of movement on substance use problems with your participants. And I remember last week someone said it's because there's not really any substance use providers on any of your teams. There is a couple, but not a lot. So I was wondering if maybe you're not seeing any movement on that because you don't have any specialists in that area on the teams.
Yeah,
or in your model.
That makes sense. And I think that that's really what we're trying to figure out. How do we build that out? Because the New Journeys model is based on Navigate, and the Navigate manuals and model doesn't have an SUD component built into it. And so I think you're right that part of what we're really looking at is how do we support our providers and support our teams in order to give them the resources and skills that they need to better support individuals in that area. The next question I see, again, this is this addictive substances or recreational? So are we talking about the substance use that is in there? Yeah, so that's any substance use. And so that's just what is being self-reported by an individual in their initial measures. The next question is, how are you going to move teachings and strategies from one tribal nation to any others when they are each individual cultures? The tribal teaching of Lummi Nation aren't going to translate well to to other tribes. And that's absolutely true. And I don't think that we're going to expect that a tribal adaptation is going to cover each and every one of the tribes. What we do think that we can do is find some general things that we could adjust. Like, for example, when we refer to psychosis, one of the things that I found in working with tribal members was calling it psychosis was sometimes not very approachable for that individual. And so maybe we can learn some things that can be applied, maybe not just to tribes, but across the board to other cultures as well. And really being mindful that when we're talking about culture, what is applicable to one person isn't going to be applicable to another. And so we really have to be culturally responsive to each and every individual and learn from their individual cultures. The next question I see here is, would the pre-screening be with the client or the referral source? And I would say both, either or. Again, going back to that no wrong door approach, we have done pre-screenings with school staff. We've done pre-screenings with jail staff. We've done pre-screenings with families. I would say it's probably less common for a pre-screening to be done with an individual, but it could happen where an individual is calling, or you're calling that person on the phone and just gathering some more information. And so we really want that to be something that's low barrier when we're thinking about pre-screening or that consultation piece of the referral process. You can just call if you're a provider or you're a family member and you have questions and you're like, hey, would this be a good fit? Is this person somebody that you would want to do more of a screening on? Just call and ask those questions. That's what a lot of our program directors have built into their schedules to be able to do. I will put my email in the chat. So if anybody has questions or wants to contact me, feel free to. What is the number we can call for a consultation? That would be really dependent upon which area that you live in. So I would reference that interactive map that is on the New Journeys virtual gathering platform. That would give you the number for whoever would be closest in the region. You can also access the New Journeys referral form online. That's just on the New Journeys website, which you can also access from the New Journeys platform. And that is an opportunity that if you're like, I don't know where this would go, you can put in that referral form and WSU manages that and would send it to the correct person. If you also have questions, feel free to just email me when I put my information in the chat here. So I know that we are out of time. Okay, there's my email. The other question is, do we ask for New Journeys consultation, and everyone should know what that is? I would just ask to speak with a program director. Say, hey, I have this person that I want to be able to staff with you. And you can give a little bit of context of what's going on. Well, thank you all for joining us today. You have a little bit of a break until 11 o'clock, and then we'll start into our breakout sessions. So thank you for joining, and I hope you have a good rest of your day. I see, Emily, you have your hand up, so I can stay on while other people are logging off.
Thank you. I'm so sorry. That was the question I was waiting for the answer the whole time. And then I got a phone call, of course. So how do we reach out to do the pre-screening? Would that be to send an email to you?
So it just depends. So I would reference the New Journeys the map on the New Journeys virtual platform
I'm
and
in
see.
King County.
You're in King County?
Mm-hmm.
So they have a team at Valley Cities, at Harborview, and at Ryther.
Mm-hmm.
So you could, theoretically, you could consult with any one of them. So you would just contact them, ask for a New Journeys program director, and they would be able to do a consultation for you.
Are you familiar with the providers in King County? I haven't had great luck with one of them. So I was wondering who you would recommend, like, would be maybe the most accessible.
I think typically any of them can be pretty accessible. Do you mind sharing who you had reached out to?
Ryther.
Okay. I would maybe try Valley Cities or Harborview.
Okay. Okay. Thank you.
Yeah. Thanks, Stephen, for dropping the locations in the chat. Any other questions before we sign off? Okay. Well, thank you all for joining. Hope you learned something today, and we will see you in the 11 o'clock.